Extrahepatic biliary apparatus. Introduction. The extrahepatic biliary apparatus collects bile from the liver, stores it in the gallbladder, and transmits it to the second part of duodenum. The apparatus consists of A. Right and left hepatic duct, B. Common hepatic duct, C. Gallbladder, D. Cystic duct, E-BILE duct. Dissection. Locate the porta hepatis on the inferior surface of liver. Look for two hepatic ducts there. Follow them till these join to form common hepatic duct. Identify cystic duct and usually green-colored gallbladder. See the point of junction of cystic duct with common hepatic duct and the formation of bile duct. Trace the bile duct in relation to the duodenum. Its opening has been seen in dissection of the duodenum. Trace the cystic artery supplying gallbladder, cystic duct, hepatic ducts, and upper part of bile duct. Right and left hepatic duct. Right and left hepatic ducts emerge at the porta hepatis from the right and left lobes of the liver. The arrangement of structures at the porta hepatis from behind forwards is: 1. Branches of the portal vein. 2. Proper hepatic artery. Hepatic duct. Common hepatic duct. It is formed by the union of the right and left hepatic ducts near the right end of the porta hepatis. It runs downwards for about 3 cm and is joined on its right side at an acute angle by the cystic duct to form the bile duct. Accessory hepatic ducts are present in about 15% of subjects. They usually issue from the right lobe of the liver, and terminate either in the gallbladder, or in the common hepatic duct anywhere in its course, or even in the upper part of the bile duct, Fig 22.3. They are responsible for oozing of bile from the wound after cholecystectomy. Therefore, it is always better to use a drain to avoid retention of bile in the depths of the wound. Gallbladder. Gallbladder is a pear-shaped reservoir of bile situated in a fossa on the inferior surface of the right lobe of the liver. The fossa for the gallbladder extends from the right end of the porta hepatis to the inferior border of the liver. Dimensions and capacity. The gallbladder is 7 to 10 cm long, 3 cm broad at its widest part, and about 30 to 50 ml in capacity parts. The gallbladder is divided into 1. The fundus, 2. The body, 3. The neck. The duct projects beyond the inferior border of the liver, in the angle between the lateral border of the right rectus abdominis and the 9th costal cartilage. It is entirely surrounded by peritoneum, and is related anteriorly to the anterior abdominal wall, and posteriorly to the beginning of the transverse colon. The hodi lies in the fossa for the gallbladder on the liver. The upper narrow end of the body is continuous with the neck at the right end of the porta hepatis. The superior surface of the body is devoid of peritoneum, and is adherent to the liver. The inferior surface is covered with peritoneum, and is related to the beginning of the transverse colon and to the first and second parts of the duodenum. The neck is the narrow upper end of the gallbladder. It is situated near the right end of the porta hepatis. It first curves anterosuperiorly and then postero-inferiorly to become continuous with the cystic duct. Its junction with the cystic duct is marked by a constriction. Superiorly, the neck is attached to the liver by areolar tissue in which the cystic vessels are embedded. Inferiorly, it is related to the first part of the duodenum. The mucous membrane of the neck is folded spirally to prevent any obstruction to the inflow or outflow of bile. The posteromedial wall of the neck is dilated outwards to form a pouch called the Hartmann's pouch, which is directed downwards and backwards. Gallstones may lodge in this pouch, Fig 22.5b. Cystic duct is about 3 to 4 cm long. It begins at the neck of the gallbladder, runs downwards, backwards and to the left, and ends by joining the common hepatic duct at an acute angle to form the bile duct. The mucous membrane of the cystic duct forms a series of 5 to 12 crescentic folds, arranged spirally to form the so-called spiral valve of Heister. This is not true valve. Functions of gallbladder. 1. Storage of bile, and its release into the duodenum when required. 2. Absorption of water, and concentration of bile. Bile may be concentrated as much as 10 times. 3. The normal gallbladder also absorbs small amounts of a loose bile salt cholesterol compound. When the gallbladder is inflamed, the concentration function becomes abnormal and the bile salts alone are absorbed, leaving cholesterol behind. Bile salts have a powerful solvent action on cholesterol, which tends to be precipitated. This can lead to the formation of the gallstones. 4. It regulates pressure in the biliary system by appropriate dilatation or contraction. Thus the normal, choletico-duodenal mechanism is maintained. Bile duct. Bile duct is formed by the union of the cystic and common hepatic ducts near the porta hepatis. It is 8 cm long and has a diameter of about 6 mm coarse. 1. The bile duct runs downwards and backwards, first in the free margin of the lesser omentum, supraduodenal part, 2 behind the first part of the duodenum, the retroduodenal part, 3 then it lies behind, or embedded in, the head of pancreas, infraduodenal part, 4 near the middle of the left side of the second part of the duodenum. It comes in contact with the pancreatic duct and accompanies it through the wall of the duodenum, the intraduodenal part. Relations. Supraduodenal part. Supraduodenal part in the free margin of lesser omentum. L. Anteriorly, liver. 2 posterior portal vein and epiploic foramen. 2 to the left, hepatic artery. Retroduodenal part, 1 first part of duodenum. 2 posteriorly, inferior vena cava. 3 to the left, gastroduodenal artery. Middle duodenal part. 1 anteriorly, a groove in the upper and lateral parts of the posterior surface of the head of the pancreas. 2 posteriorly, inferior vena cava. The course of the duct through the duodenal wall is very oblique. Within the wall the 2 ducts usually unite to form the hepatopancreatic ampulla, or ampulla of Vater. The distal constricted end of the ampulla opens at the summit of the maw, or duodenal papilla 8 to 10 cm distal to the pylorus. Sphincters related to the bile and pancreatic ducts. The terminal part of the bile duct is surrounded just above its junction with the pancreatic duct by a ring of smooth muscle that forms the sphincter choleticus, choleticus bile duct. This sphincter is always present. It normally keeps the lower end of the bile duct closed, Fig 22.7. As a result, bile formed in the liver keeps accumulating in the gallbladder and also undergoes considerable concentration. When food enters the duodenum, especially a fatty meal, the sphincter opens and bile stored in the gallbladder is poured into the duodenum. Another less developed sphincter, which is usually but not always present around the terminal part of the pancreatic duct, is the sphincter pancreaticus. A third sphincter surrounds the hepatopancreatic ampulla and is called the Sphincter Ampulli or Sphincter of Oddi. Arteries supplying the biliary apparatus. 1. The cystic artery is the chief source of the blood supply, and is distributed to the gallbladder, the cystic duct, the hepatic ducts and the upper part of the bile duct, Fig 22.8. 2. Several branches from the posterior superior pancreaticoduodenal artery supply the lower part of the bile duct. 3. The right hepatic artery forms a minor source of supply to the middle part of the bile duct. The cystic artery usually arises from the right hepatic artery, passes behind the common hepatic and cystic ducts, and reaches the upper surface of the neck of the gallbladder, where it divides into superficial and deep branches. Venous drainage. 1. The superior surface of the gallbladder is drained by veins which enter the liver through the fossa for the gallbladder and join tributaries of hepatic veins. 2. The rest of the gallbladder is drained by 1 or 2 cystic veins which open into the right branch of the portal vein. 3. The lower part of the bile duct drains into the portal vein. Lymphatic drainage. 1. Lymphatics from the gallbladder, the cystic duct, the hepatic ducts and the upper part of the bile duct pass to the cystic node and to the node of the anterior border of the epiploic foramen. These are the most constant members of the upper hepatic nodes. The cystic node lies in the angle between the cystic and common hepatic ducts. It is constantly enlarged in cholecystitis. 2. The lower part of the bile duct drains into the lower hepatic and upper pancreaticospinal nodes. Nerve supply. The cystic plexus of nerve, supplying the territory of the cystic artery, is derived from the hepatic plexus, which receives fibers from the coeliac plexus, the left and right vagi and the right phrenic nerves. The lower part of the bile duct is supplied by the nerve plexus over the superior pancreaticoduodenal artery. Parasympathetic nerves are motor to the musculature of the gallbladder and bile ducts, but inhibitory to the sphincters. Apathetic nerves from thoracic 7 to 9 are vasomotor and motor to the sphincters. Pain from the gallbladder may travel along the vagus, the sympathetic nerves, or along the phrenic nerves. It may be referred to different sites through these nerves as follows. A. Through vagus to the stomach, epigastrium. Through the sympathetic nerves to the inferior angle of the right scapula. Lateral horn of thoracic 7 segment of spinal cord gives sympathetic fibers to coeliac ganglion through greater splanchnic nerve. T7 segment receives pain fibers from skin over inferior angle of scapula. So visceral pain is referred to somatic area. A. Through the phrenic nerve to the right shoulder, C4 gives fibers to phrenic nerve and supraclavicular nerves. Biliary obstruction arises when passage of bile into the duodenum is blocked either completely or partially. Obstruction may be intrahepatic or extrahepatic. Causes are, A. The gallstones which slip down into the bile duct and block it. B. Cancer of the head of pancreas which compresses the bile duct. In these cases, since bile pigments will not reach the duodenum, faces will be light-colored. Instead, bile pigments reach the blood, causing jaundice, and as these are excreted in urine, cause it to be dark-colored. Combination of light-colored stools with dark-colored urine implies obstructive jaundice. If it is associated with episodes of pain, it is likely to be due to gallstones. If it is associated with loss of weight, etc., it is likely to be due to cancer of head of pancreas. Bile duct can be assessed from the duodenum by a procedure endoscopic retrograde cholangiography, ERCP. Referred pain, pain of stretch of CBD or gallbladder is referred to epigastrium. It is also referred to right shoulder arid inferior angle of right scapula. Humeral control of the gallbladder contracts when food rich in fat enters the duodenum. The fat causes certain cells in duodenum to liberate a hormone called cholecystokinin-. The hormone is carried to the gallbladder and causes its contraction. It also causes dilatation of the sphincters. Gallbladder function can be investigated by ultrasound. Inflammation of the gallbladder is called cholecystitis. The patient complains of pain over the right hypochondrium radiating to the inferior angle of the right scapula, or to right shoulder. When a finger is placed just below the costal margin, at the tip 1/9 costal cartilage, the patient feels sharp pain on inspiration. He winces with a catch in his breath. This is referred to as Murphy's sign, Fig 22.11. Stories may form in the gallbladder. The condition is called cholelithiasis. They typically occur in fat, fertile, female of 40, but also in males. The stones are responsible for the time-to-time spasmodic pain called biliary colic. In these cases, Murphy's sign is of great diagnostic value. Gallstones never develop in dog, cat, sheep, rabbit because of high fatty acid content of their bile. Stones are common in man, ox, and hog because of low fatty acid in them. They can give rise to severe spasmodic pain which is called biliary colic. The region of the gallbladder is frequently operated upon. It is, therefore, necessary for the surgeon to be aware of the numerous variations that may exist in the extrahepatic biliary apparatus, and in the related blood vessels. The operation for removal of the gallbladder is called Cholacystectomy. The most significant lesions of typhoid fever occur in lymphoid tissue, bone marrow, and gallbladder. Gallbladder is invariably infected in these cases, and the carrier state may be due to persistence of typhoid bacilli in this organ. Courvoisier's law, dilatation of the gallbladder occurs only in extrinsic obstruction of the bile duct like pressure by carcinoma of head of pancreas. Intrinsic obstruction by stones do not cause any dilatation because of associated fibrosis. Gallbladder is related to duodenum. The gallstones may penetrate wall of gallbladder and duodenum to get into the lumen of duodenum. These stones travel through the coils of small intestine and may block the narrow ileocecal junction leading to intestinal obstruction. Callose triangle, triangular space formed by cystic duct, common hepatic duct and segment V of right hemi-liver form CU/OT's triangle. This space contains cystic artery, cystic lymph node and autonomic fibers reaching the gallbladder. Histology. Mucous membrane, it is projected to form folds. Epithelium consists of a single layer of tall columnar cells. Lamina propria contains loose connective tissue. The fibromuscular coat, it consists of smooth muscle fibers and collagen fibers which rests on an outer fibroareolar coat. Development. Hepatic bud arises from the endoderm of caudal part of foregut. The bud elongates cranially. It gives rise to a small bud on its right side. This is called pars cystica and the main part is PNRS hepatica. Pars cystica forms the gallbladder and the cystic duct, which drains into the common hepatic duct, CHD. Pars hepatica forms CHD and divides into right and left hepatic ducts. These ducts reach septum transversum and proliferate to form the HEPA-IIC parenchyma. The entire epithelium is endodermal and other layers are of splanchnic origin. Gallbladder stores as well as concentrates bile. So it is more liable to have gallstones. There is lot of variability in the origin of cystic artery as well as in the pattern of joining of cystic duct. This has to be kept in mind during surgery of this region. Pain of cholecystitis may be referred to epigastrium, right shoulder and inferior angle of right scapula.